I will take this occasion to seek your blessings as well as invite you to a series of
We are
workshops
live.
on the skills.
So we are
Hello.
live.
Hello. Good evening, everyone. I'm Dr. Tinku Bali, and on behalf of the Academics and Research Committee, I welcome you all to this 73rd episode of the ARC AIOS PG teaching program. Well, this is a PG teaching program with a difference because in this, we cover topics that are not covered by other PG teaching programs. And information that is not readily available to postgraduates is provided during these webinars. So every Thursday, we either have a didactic lecture on, newer advancements or interpretation of common diagnostic modalities, case presentations, and today we have a journal club. So, journals, as we all know, are a great way to update our knowledge. But before we can apply the information that a journal article gives us, it's very important for us to know whether that knowledge is authentic, correct, and relevant to our practice. So, keeping that in mind, today we have two journal articles. The first one will be presented by Dr. Neha Kumari, who's a first year resident at the Hindu Rao Hospital, and the second by Dr. Ketha Supriya Reddy, who's from Netradhama, a super specialty eye hospital, Bangalore. So we also have a very stellar panel of discussants with us, and I welcome them all this evening. We have Dr. Umang Mathur, who's the CEO and consultant cornea at the Shroff Charity Eye Hospital, New Delhi. We have Dr. S.J. Sai Kumar, who's the medical superintendent and head of cataract and glaucoma services at the Giridhar Eye Hospital, Kochi, and Dr. Suresh Kumar Gupta, who's professor and head, Government Medical College and Hospital, Chandigarh. So, a very warm welcome to you all, and thank you so much for sparing time today and being with us this evening. So, with that, I now invite the first presenter, Dr. Neha Kumari. As I mentioned, she's a resident at the Hindu Rao Hospital, Delhi, and she has been ably mentored by Dr. Jatinder Bali, who's the CMO at the Hindu Rao Hospital. So she will be speaking on reusing surgical materials for cataract surgery and assessment of potential contamination. A very relevant and useful article. So let's see what she has to say. And I request the discussants that you're free to interject at any point there where you want more information or you want a clarification. Please feel free to interject. And with that, I invite Dr. Neha Kumari to present the journal article. Dr. Neha, over to you.
Good evening, everyone. I'm Dr. Neha Kumari, going to share my PPT. Is it visible?
Yes, it is. You could make it full screen, please.
Yes, it's you're visible.
Good evening, respected seniors and my dear colleagues. I'm Dr. Neha Kumari, DNB resident from Hindu Rao Hospital, is going to present an article under the mentorship of Dr. Jatindra Bali. I would like to thank AIOS ARC committee for this opportunity. The title of this article is Reusing Surgical Material for Cataract Surgery, an Assessment of Potential Contamination. It was published in Journal of Cataract and Refractive Surgery in October 2024. As we all know that cataract surgery is the most frequently performed operating procedure in ophthalmology. Approximately 29 million cataract surgery were operated in 2019, out of which 4.2 million were done in US and 7.4 million in India. Healthcare system account for substantial percentage of greenhouse gas emission that poses a major threat to the global public health. This has focused our attention on unnecessary operating room waste. In a survey of North American and European cataract surgeons, attitude towards the operating room waste, more than 30% of the respondents were met factors and excessive and need to be reduced. Arvind, I can
Doc-
The
Dr. Neha,
system performs more than overall across all 14 hospitals in. Hello,
Dr. Neha, can you switch off your video
am I
and then
audible?
continue? Yeah, your voice is breaking. Can you just switch off your video and then continue? That way, the bandwidth consumption will be less. I think there is an issue with the voice. Just switch off your video if you can.
You can shut off the video
Yes,
stream.
yes.
Yeah.
Please continue.
Now you can hear me?
Yes.
Loud and clear.
So the Arvind Eye Care System they follow a standardized OR protocol across all the 14 regional eye institutes. This which include that the reuse of the surgical material is which were mandated for single use. This reuse strategy has allowed the Arvind Eye Care system to approximately reduce 60% of its surgery at little to no cost. This reuse is the reason that the carbon footprint of one phaco surgery at Arvind Eye Care system is 5% of that in the UK. Coming to importance of carbon footprint, it has a climate impact. Carbon is a significant contributor of global greenhouse gas emission. The developed countries have a significantly higher carbon footprint as compared to the resource efficient model countries. Reducing the footprint also support the high volume and eco-friendly solution. It also has a health and environmental benefits. A retrospective registry study found that the Arvind Eye Care system post-operative endophthalmitis rate of 0.04% in 2 million cataract surgery that used the standardized OR protocol during 2011 to 2018. The reuse is not allowed by the manufacturer and the regulatory agencies in US because of the assumed risk of cross-contamination which may lead to post-operative endophthalmitis. But during 2013 to 2017, the American Academy of Ophthalmology IRIS registry reported identical 0.04% post-operative endophthalmitis rate in 8.5 million cataract surgery. The fact that the routine reuse of the surgical instrument did not increase the post-operative endophthalmitis rate in Arvind Eye Care system suggests that the cross-contamination may be minimal or insignificant with appropriate protocol. So the study was done to evaluate the contamination risk in reused surgical materials. The objective of the study was to investigate the bacterial and fungal contamination in the used materials. The study was carried out at Arvind Eye Hospital. It was a prospective longitudinal cohort study done during a period of May to October 2022. In this study, the surgical devices and supplies that were reused were divided into three groups. Group 1 contained the surgical devices that contacted the patient's eye and ocular surface. Group 2 contained the surgical devices that did not contact the ocular surface directly. And Group 3 contains the irrigation fluid. In Group 1, the surgical devices were cleaned and sterilized using the immediate use steam sterilization after each case before reusing it for the next case. After immediate use steam sterilization, the instruments were directly inoculated in blood and potato dextrose agar. Group 2 consists of instruments that did not came in direct contact with the ocular surface like the phacoemulsification handpiece and tubings or coaxial irrigation aspiration handpiece. These devices were continuously reused without reprocessing or re-sterilization for all cases in one single surgical day. At the end of the day, the handpieces were inoculated on blood and potato dextrose agar, and small section of the tubing was extracted using a sterile blade, and then they are submerged in a brain heart infusion broth. Group 3 consists of balanced salt solution, which was used for 4 to 5 consecutive cases until they were nearly empty. The 2 ml of the residual fluid was then extracted and it was put in a thioglycolate broth. All samples were collected by a trained study coordinator from a microbiological lab. All samples plated on blood agar were incubated in carbon dioxide incubator at 37 degrees centigrade, and those plated on potato dextrose agar were incubated at 25 degrees centigrade for fungal growth. Total 3,333 samples were collected and they were monitored over a period of 7 days. So coming to result, there was no bacterial or fungal growth in any of the sample, no cases of post-operative endophthalmitis in 3,241 surgeries over a period of 6 weeks post-operative follow-up. The historical post-operative rate of 0.04% with the reuse protocol at Arvind Eye Care System was matching the Western countries with single-use surgical devices. Since the reuse is not allowed by the manufacturer and regulatory agencies because of the risk of cross-contamination, they are prohibited. Single-use labelings in the Western countries, they are prohibited. Based on this study, we can say that with efficient sterilization, reuse of the surgical material is safe with no risk of increased risk of infection. Reusing is also having environmental and economic benefits, like it helps to reduce the medical waste, also reduces the carbon emission significantly, and provide us a cost-effective healthcare system. Recommendations based on this study is to reassess the regulatory restriction on single-use item because some of the products there may be no significant evidence or concern that the reuse is dangerous, but significant cost validating reuse may lead the manufacturer to categorize them as a single-use by default. So warnings like the product should not be reused is important if there is a proven danger or any known danger. Further studies and research is required because the risk or safety of reusing certain surgical supplies cannot be drawn from this study alone. The lack of positive culture does not guarantees that microbial contamination was not there or there was a zero risk of contamination. Also, no study was done on any viruses or microbiological contamination. So this demands further study on more sustainable practices that does not compromise the patient safety and also encourages the uh, implementation of effective sterilization protocol in high volume settings. Thank you.
Thank you, Dr. Neha Kumari. Dr. Jatinder Bali, would you have anything to add to this? Why did you choose this article and what did you want to convey through this? And your your critique of this article in 1 or 2 sentences. Dr. Bali?
There are 2 or 3 things that stand out. First is the regulatory framework for single-use devices. It says that they say it is not safe for reuse. They've not tested it for a reuse, so probably we have this was a very recent article. We are aware of these practices across the country. And this was an article which is forcing us to ask questions. It has a clinical impact. It does have certain limitations. It's not looking at prions. It's not looking at viruses. It's just looking at early post-op endophthalmitis. It is looking at bacterial and fungal contamination only. And no proof of harm is not the same as proof of no harm. So is it really time for us to change our practices? The answer is no. But yes, it is time for us to start thinking about how we are developing the regulatory protocols for the devices. And the study design also is very interesting. It is we have a global standard. We have something equivalent to a global standard. So the outcomes are measured there. And then the potential risk factors are being covered. What this actually is leading us to is something what we call acceptance sampling and the P charts, which are not really part of our what do you call it, surgical systems. They are used in automobiles and high-end engineering products. So yes, we need to have a rethink. This the primary idea of picking up this article was the study design, the impact that this study has, and and the very fact that it comes from India. Thank you so much.
Thank you so much. So with that, I now request the discussants, Dr. S.J. Sai Kumar. So if you would like to, critically evaluate this or ask any questions, you're welcome.
Yeah.
Sir.
Good evening, all of you, and thank you for having me in this ARC journal webinar. I think it really gives us an insight into how we should, work in the OT, because in the article itself it is mentioned that initially all these practices were developed for general surgery and other surgeries, and then only we sort of thought that that stringent protocols may not be required in ophthalmology, and this study I think is definitely proof that the standards of care, the way we sterilize our instruments, are all slightly different for ophthalmology. It's not that we should be not careful or anything, but it need not be as stringent as certain other surgical procedures in the human body. Now, many of these, I think most of us are sort of following the protocols that the Arvind is using. I'm not sure about the other. I mean, we don't use street clothes into the OT. We have OT dresses, but they are telling that you can even walk in with a street cloth and then just cover and proceed with the surgery. So there are some differences here and there, but I don't think. Maybe in a few institutes, yes, but generally the US protocols, I don't think are being followed in India. So that way, I think, this article prompts us to look at our practices very, very carefully. And as you mentioned, the limit, it's already mentioned in the limitations, it is confined to the early post-op endophthalmitis, but fungal is also studied. So that is a good factor. So you look at bacterial and fungal growth, but long-term things we really don't know. But I think definitely the sort of stringent protocols used in general surgery may not be applicable for ophthalmology. I think that is the takeaway from this journal article. Thank you.
Thank you. Thank you, sir. Dr. Suresh Kumar Gupta, sir, could you
Yes.
please add your comments?
Very good evening to all. And at the outset, I am grateful to AIUS ARC, Dr. Prashant, Dr. Tinku for giving me the opportunity. And Dr. Sai Kumar also highlighted this. This is a good study. And if we look at our practices in various institutes, medical colleges, and even in private sector, in fact, we are all following this type of what I will call economic measures. So, in a resource scarce country like India, we can't have everything single-use item in our OTs. And apart from this greenhouse gas effect and a lot of carbon imprint, it is economical factors. So we have to in fact reuse most of these items which are basically from manufacturer's point of view, it's for single use. And I think during COVID, all of were concerned with aerosolization and spread of virus during all surgeries, including cataract surgery. But then evidence came that during cataract surgery, which is a very clean surgery as compared to if we look at GIT surgeries and all other major surgeries, whether in orthopedics or in surgery and even gynae, uh, we are much less likely to cause there are no body fluids which are spread on the floor or other contaminants. So we should not be that stringent with cataract surgery. And since cataract surgery is one of the most commonly done surgery in the world, and if we can decrease the economic burden on our patient by reusing or re-sterilizing whatever items we are using, it will be very cost effective. And I don't know about the regulators in our country whether they are going to help us in this, but we have to use these things and do these things off label as we are doing with Avastin. So Avastin is also not regulator authorized, but we are still using it. So similarly, we have to continue these practices, and it's really good study. And Arvind group of institutes have provided us evidence. We were all doing, but there was no documented evidence. And now we have the evidence that it is not likely to cause more incidence of endophthalmitis, and we are safe to, it is safe to reuse these items. Thank you.
Thank you, sir. Thank you so much for your comments. So yes, I think this is a very relevant study articles which has a lot of takeaways for us that we can actually use in our clinical practice. And Dr. Neha Kumari has very ably brought out the, the lacunae in the study, the limitations of the study that we should all keep in mind before we apply the take-home messages from the study. So with that, we move on to the next journal article, and that will be presented by Dr. Keta Supriya Reddy, who's a DNB resident at the Netradhama Super Specialty Hospital, Bangalore. And her mentor is Dr. Supriya Sriganesh, who's a consultant cataract and refractive surgery at the Netradhama Super Specialty Eye Hospital, Bangalore. So over to you. Her journal article is Reading the Performance Following Contralateral Implantation of an Extended Depth of Focus IOL and Hybrid EDOF Multifocal IOL. So this again promises to be a very interesting article. Over to you, Dr. Supriya Reddy.
Thank you, ma'am. My name is Dr. Supriya Reddy. I am presenting you an article of regarding phycorefractive, and my mentor is Dr. Supriya Sriganesh. Everyone can see the slides, sir?
Yes.
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 My topic of today's presentation is reading performance following contralateral implantation of an extended depth of focus IOL and a hybrid EDOF multifocal IOL. This is done under the author B. Vandenberg, published in the Journal of Refractive Surgery in the year 2024. It is a prospective study. As we know, nowadays cataract surgeries are becoming more like a refractive surgery, like an independent of spectacles. That's why there are a lot of IOLs are coming into subjective nowadays. There we are having a lot of presbyopic correcting multifocal and extended depth of focal IOLs. These are becoming revolutionized into the field of refractive surgery by providing good vision at multiple distances and spectacle independence. So the use of continuous text reading acuity charts with proven validity and reliability is preferred for accurate assessment of reading performance. The Salzburg Reading Desk is a tool for evaluating the functional assessment. It is used frequently to assess the reading performance following the implantation of presbyopia correcting IOLs. Purpose of the study is to assess the objective reading performance at intermediate and near distances using the Salzburg Reading Desk in a patients with cataract who underwent the implantation of diffractive extended depth of focus IOLs in the dominant eye and a hybrid multifocal EDOF IOL lens in the non-dominant eye. This is a prospective non-cooperative interventional study done with the patients who underwent the bilateral cataract surgery, implantation of the Technis Synergy IOL in the non-dominant eye, and implantation of Technis Symphony IOL in the dominant eye, done under the Ethics Committee approval adhered to the declaration. This is the pictures showing the Technis Synergy IOL on the left side and Technis Symphony IOL on the right side. We taken the inclusion criteria of the patients 40 years or older who required bilateral cataract surgery, wished to achieve the spectacle independence, suitable candidates, and patients had to have a predicted post-op astigmatism of 0.75 diopters or less, who is willing to provide written informed consent and adhere to the study requirements. Exclusion criteria: if there is any history of ocular surgery, including laser refractive surgery or glaucoma surgery, history of any ocular trauma, ocular comorbidities, macular degeneration, and any corneal scars. So all eligible patients underwent the bilateral cataract surgery and implantation of the Technis Synergy and Technis Symphony IOLs according to the eye dominance test. Eye dominance test was determined by the classic methods. After correcting for the distance, the SRD was... Ma'am? Hello?
Yeah, please carry on, doctor.
Carry on.
Okay, sir. After correcting for distance, SRD was used to assess the reading performance at near and intermediate distances at 6 months interval. SRD device, this is the image showing the patient performing the SRD test. SRD test consists of a computer with a microphone. SRD test is mainly used to record the reading time, reading speed, and how many words per minute, and reading acuity is done. This screen displays logarithmically in the selected language. According to it, the screen illumination, contrast, and inclination can be standardized. It will record the words per minute. The distance is measured continuously by using the cameras. The statistical analysis is done, and the results were showing 30 patients with cataract surgeries were enrolled out of total 60 eyes, out of which 46 eyes underwent the SRD assessment. This is the logmar bar graph showing the preferred intermediate and the preferred near acuities of 0.07 for the intermediate and 0.13 for the near. This is the table explaining the monocular and binocular distance acuity preferred for the intermediate distances. The reading acuity was statistically significant with p-value of 0.001. Although the reading speed, distance, and reading time was not statistically significant. And the same monocular and binocular distance for the corrected preferred for the near reading acuity, where the reading acuity is statistically significant with p-value of 0.001, and the smallest log scaled print size is significant with p-value of 0.034. As similar to the previous table, reading speed, distance, and time was not statistically significant. So monocular reading acuity at the preferred intermediate distance was significantly better in the eyes implanted with the EDOF IOLs. On the other hand, eyes implanted with the hybrid EDOF multifocal IOL showed the better reading acuity at the near distances. Discussion. We assessed that the reading performance using the SRD after implantation of the Technis Synergy and Technis Symphony IOLs. The EDOF IOLs elongates the depth of focus, allowing a continuous range of vision, mainly between the far and intermediate distances. The hybrid multifocal EDOF IOLs aims to achieve good vision across the full range of distance, intermediate, and near visual acuity. It was hypothesized that implanting the Technis Symphony in the dominant eye and Technis Synergy in the non-dominant would result in excellent binocular, intermediate, and near reading acuity. These binocular outcomes at patients' preferred intermediate distances are attributed to the strengths of the two IOLs. There is a similar study performed evaluation of reading performance in refractive lens exchange with a diffractive continuous range of vision intraocular IOLs. Here, the patients were taken as a refractive lens exchange. They concluded that uncorrected intermediate and near reading function considerably improved after bilateral implantation of the Technis Synergy IOLs. Patient preferred a closer near and intermediate distances to set distances. One more study, clinical evaluation of an extended depth of focus intraocular lens with the Salzburg reading test. This concluded that EDOF IOLs provide a wide range of improvised visual and reading function between the far and intermediate distances, and also improved the near visual acuity. Conclusion. According to this study, patient implanted with hybrid multifocal EDOF IOL in the non-dominant eye and a diffractive EDOF IOL in the dominant eye achieved excellent reading acuity and speed for the intermediate and near distances. Thank you.
Thank you, Dr. Supriya Reddy. This was an interesting article, which gave a new take on an age-old, problem that we have been seeing. So I now request Dr. Supriya Sri Ganesh to give her, her viewpoints on this article. How would she evaluate this article critically? Was it a good study? Was the patient selection fine? And would you use this kind of, lenses in your practice? So,
Thank you,
Dr.
ma'am. And thank you, AIOS, ARC, and Prashant sir for this opportunity. The reason we thought this study was important is because basically we provide our patients two options when they want spectacle independence. It's either a multifocal lens or an EDOF lens. The issue with EDOF lenses is that it gives you a range between distance to intermediate, but patients still need reading glasses. And with multifocals, you get a lot of glare and halos at night. So this study looks at a mix and match of these lenses to provide better outcomes in terms of range of vision while also minimizing the impact on function. And the one important thing is that they've used the Salzburg reading desk. This is a tool to assess functional vision. So basically, the patient sits in front of a computer screen and reads reads words and sentences off that screen, which keeps reducing in size, and the reading speeds in words per minute is calculated. And there are also cameras which assess the distance. Now, one of the positive things that they've done in this study is that they have assessed the preferred reading distance of the patient and preferred intermediate distance of each patient rather than keep a fixed intermediate and reading distance. So these IOLs have a fixed distance at which they work the best, and most studies are done at these distances. But this doesn't really give real world data. So what they've done in this study is they have asked the patient to set their preferred distance, and then they have evaluated. So that is a positive aspect of the study. However, I feel like there is a flaw in terms of dominance. So when we have cataracts, you cannot really assess dominance. Another thing is that in the exclusion criteria, they have not really excluded mature cataracts, dense cataracts. They have not only taken early NS, in which it would be more easy to assess dominance. And in this paper, they have actually said that they have assessed motor dominance, and if not possible, then they have assessed sensory dominance. But even sensory dominance, which means that two different images are presented to both eyes and you see which eye the patient sees the image clearer. But with cataracts, even that wouldn't really work to properly assess the dominance. So I feel like that's a fundamental flaw of the study. And also the lenses themselves, basically they have said that with the EDOF lens, monocularly, the intermediate vision and reading speeds are better. And with the multifocal, the near vision is better. But with the multifocal, they have not given any difference in terms of the two eyes for near reading speeds. So if you see the results, the reading speed of both the eyes for near, it's not statistically significant. This is interesting and a little hard to believe, because for the EDOF lens, it doesn't actually provide a very good near vision, but they have said that it's equivalent reading speed to the multifocal lens. So this is probably one flaw as well in the study. And they've also not spoken about MTF, contrast. They have not taken a night vision questionnaire, subjective questionnaire for glare, halos, etc., which is all very important for functional vision. So that could also have added more value to the study.
Yeah, thank you, Dr. Supriya. You highlighted some very relevant flaws in the study, and we all should take this with a pinch of salt. Whenever we are analyzing a journal articles, these are the points that we should critically evaluate in our mind before we apply it to our practice. So just an offshoot of that, have you ever tried this in your practice, this kind
We
of a
have.
scenario?
We
And
have.
how
We
did
have.
it work for you? Did it work the same way that it did in this article?
It works well and patients are quite happy. However, we don't do the dominance testing. The first eye that gets operated, we implant the lens, which is relatively better for distance, that is the EDOF lens. Here, the Technis Symphony is an EDOF, but it's a diffractive EDOF. So at the end of the day, although they say that it stretches the depth of focus, it's still a diffractive principle. But the synergy kind of offsets that, because initially it was, what they've done is they've taken the Technis multifocal with a +4 add, which had excellent near vision at 33 centimeters, and they have superimposed the Technis Symphony on top of that. So it's two technologies. So in the synergy, you can actually see double rings. So that gives a good near vision, and they say that it's a combination of two technologies. So it does work well, and we have seen a similar effect in our practice as well. However, we can't really only assess it with the SRD. We also have to do other tests for functional vision, and the dominance part of it is not very reliable.
Thank you. Thank you so much for summing it up so well. So now I would like to request the discussants to get on board. And I now request Dr. Umang Mathur. Dr. Umang Mathur, I know you've joined late. So just for your benefit, I would just like to reiterate that this journal article was one where they implanted a Technis Synergy lens in one eye and a Symphony
Yeah,
lens in the other eye.
yeah, sure.
Yeah. So what is your take on that, and what is your evaluation of this article? Is it something that we could apply in our clinical practice?
Absolutely. I think there's a lot of interest in mix and match of IOLs, and I think uh, like one of the other problems that you have with some of these lenses that they cut off significant light, and the patient requires more light. And so if you have a lens that is giving the patient pretty good near vision but not happy with the light situation also, sometimes a mix and match helps. So it's something that the brain is able to adapt to. And looking at, I think it's good to do a conservative approach in the first eye and then see what the patient is wanting, and uh, you can decide on what kind of near vision the patient now expects. But I think contrary to what we thought initially, that you have to put only the same kind of lens in both eyes, I think there's enough evidence that the brain is able to adapt, and you can give a better range to the patient. So, of course, you need to know what kind of lens you're putting and what are the advantages, disadvantages, and how you can correct it. So, unfortunately, most of us get used to a particular platform, and we often don't have a lot of experience of our own in the range of different companies and what kind of platform they're using. But it's an interesting topic but I would agree, some of these studies need to have a little more rigor to be able to take all the conclusions, and I think very nicely critiqued that you have to take some of the conclusions with a pinch of salt, and but it's an interesting area to work on.
Thank you. So, Dr. Sai Kumar, sir, what is your take on this article?
Yeah, I think the concept of the Salzburg reading desk seems to be very, very exciting, because it's much more than the normal near vision charts that we use. So the distance is looked at, the reading speed is looked at, the lighting is looked at. So I think that is very exciting. The concept of mix and match has been there for many years. There is nothing excitingly new in the mix and match technology. And if you look at the Symphony versus the Synergy, the side effect profile or the glare halo profile are pretty similar in both. There is maybe a slight difference, but they are pretty much similar. And my experience with the Synergy has been that it gives excellent near as well as intermediate vision. Because as Dr. Supriya very rightly said, it is something like a superimposition of two technologies, and intermediate vision is pretty good. So with a similar side effect profile, I would rather do a synergy in both eyes than opt for a symphony. I mean, this is my personal opinion. I'm sure there will be differences of opinion in the mix and match. So this is the way I look at it. One of the exclusion criteria things, which I don't know whether I missed it or it was not mentioned, are the progressive zonulopathies. Now, in progressive zonulopathies, I think especially the diffractive IOLs, and I am sure people of my generation who have been doing cataracts for 25, 30 years, we are now seeing the dead bag syndromes, the IOLs which are moving this way, that way, dropping, decentering. So these are a reality that we are facing nowadays. And compared to say 5 years or 10 years back, we are refixing or removing IOLs and implanting new lenses more frequently nowadays. So these are things that has to be kept in mind in the future also when we talk about these steps, because these are all studies where you look at the immediate post-op vision, immediate near vision, intermediate vision, and that's it. So these are things that has to be sort of kept in mind. And if intermediate vision is the predominant thing that we are looking at, for example, we are all into laptops and mobiles and things like that. So I would rather go for a bilateral EDOF. And for me, no financial interest in any way. For me, the ideal EDOF without side effect is the VVT. So I would rather go for a bilateral VVT. And as I need not mention here, all of us know chair time is extremely important. So even if you go for the symphony first and then the synergy, what is the wow effect for a patient who undergoes a multifocal? It is the reading. That is the wow effect. So if you put the symphony first and tell him, no, now you can't read, I'll put synergy in the second eye, then you will be able to read. I mean, so you have to really sit with the patient, explain why the dominant eye I'm going to put the symphony, why the other eye, non-dominant, I'm going to put the synergy, and how you'll be able to get both intermediate and reading after I implant both lenses. So I think you have to properly explain to the patient before. This mix and match technology looks very fascinating in the out in the when you talk about it, but when you really sit with the patient and talk and find out their real need and their passion for reading, all those things, then I think we'll have to take a call. These are my personal views. So having said that, the article was well presented and very well critiqued. I think Dr. Supriya, I congratulate you for that, because whenever you talk about articles, you always tend to highlight the positives of the article, but you have very clearly highlighted the flip side of the article as well.
Thank you
Thank you
so
very
much,
much.
sir.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Sai Kumar. You very nicely highlighted some practical problems that we could encounter, when you're selling these lenses to patients. So with that, I now request Dr. Suresh Kumar Gupta to give his critical evaluation of this article. And also
Dr.
whether this is something, sure. So
Yeah,
please go ahead.
Dr. Mang and Dr. Sai Kumar have very nicely summed up, so I have nothing more to add. I have just one question from Dr. Supriya Reddy regarding SRD, the Salzburg Reading Desk. Is it available free of cost on internet, or you have to purchase the software or something to assess this test?
So this is actually a complex set of, this is an instrument which requires a separate room. There is a monitor, there is a laptop, there is a mic for the patient to speak into, and there are two video cameras that are constantly recording the whole thing, the distance between the patient and the screen, etc. So it's an elaborate setup. We do have it at our practice, and we do use it mainly for research purposes, but it is quite a helpful tool. It's not really available in India, so it has to be purchased from the US and then brought here. So it is quite an expensive setup as well.
So it's not free of cost available on internet, and then it's not practical. It can't be used in most of the setups in India. So
Yes, sir. It's mainly for evaluating these lenses.
over routine and charts, Jagger charts, they are, it's more dynamic and gives much more information regarding air dynamics of vision. But as Dr. Sai Kumar highlighted, the mix and match is going to stay. I think the company came up with Synergy because with Symphony the near vision was still a problem. So they added +4 and made it more comfortable and useful for near vision. But again, it will create problems for your intermediate and distant vision. So then mix and match is going to stay. So as Dr. Sai Kumar highlighted, that wow factor has to be there. So because both the modalities are going to stay, whether you are using same lens in both the eyes or you are doing mix and match, you have to take a call and customize it as per patient requirement. And as Dr. Sai Kumar highlighted, chair time. Whenever you are going to implant these type of lenses, you have to spend time. We just can't force things on the patient. We have to talk to them, discuss, look at their perspective, and then take final. Thank you.
Thank you, sir. So just a spin-off from this is a different clinical situation wherein the patient has had a monofocal lens implanted, a few years ago, and now wants to get a EDOF or a multifocal lens. So would you recommend that? And in your clinical experience, are the patients happy after this? Or to the panelists, Dr. Umang?
I can't say I've done a lot of them, but I have done, and it does work. So if somebody has a monofocal, you can put a lens that is intermediate. Again, I too have shifted more to intermediate, and I have more experience with Vivity than with any other lens. But yes, it can be done. You can add that little intermediate or near vision to it. The patients do accept it. So it's not something that cannot be done. Uh, so and again, my take would be generally I would do a mix and match when the first eye the patient is not too happy. If your first eye the patient is happy with the vision, then I would probably just add to the happiness and not try to mess around a lot with it.
Dr. Sai Kumar, sir?
Yeah, I think I have to agree completely with what Dr. Mathur said. For me also, mix and match is somewhere, you implanted one lens, the patient is not happy either with reading or with intermediate, and then you go in for a mix and match. Suppose you put a symphony in one eye, patient is not happy with reading, then probably I'll go for a synergy for the second eye. But otherwise, this has been a prospective study. This is a proper study where they have decided that dominant, they're going to put a symphony, the non-dominant they are going to put synergy, and they have studied it. Fair enough, that is okay for the study. But in clinical practice, I think I would agree with what Dr. Mathur said. And I have also implanted very few lenses with monofocal in one eye and an EDOF or a multifocal in the other eye. It does work, there's no problem. But then, the monocular near vision addition, that problems will be there. One eye is predominantly for distance, the other eye you use for near and intermediate. There is no harm in doing that, but probably not the ideal thing to do.
Any other panelist, anything else that you'd like to add? Dr. Supriya, any parting remarks?
Ma'am, I also agree that basically my thing was that the first eye that you're operating, if you're either putting a multifocal or an EDOF, if you're putting an EDOF, patient is not happy with the reading with that EDOF, then it would make sense to put a trifocal in the other eye. If you've put a trifocal in the first eye and the patient has a lot of glare halos, it makes sense to put an EDOF in the second eye. So that way it kind of helps that we have this information about mixing and matching. But otherwise, yes, the synergy works well for both intermediate and near, and generally, if they're happy with that for the first eye, we would implant the same thing in the second eye.
But I don't know whether you can call the symphony a truly EDOF lens, because it still is the diffractive. Yeah.
Yes,
It
yes,
still is the
sir.
diffractive
It's
platform.
at the end of the day, it's
yes.
it's
It
a
still is the
diffractive.
diffractive platform. It still has, although not as much as the other lenses, it still has
Yes.
glare and halos.
Exactly.
So,
yeah.
So I think
Completely agree.
Dr. Gupta, I had a query. Yeah, if I could. I had a query, Dr. Gupta. Like the dropout rate seemed to be in the rate of something like 25% in this study. So probably we're looking at some sort of a regression towards the mean. And that is why, where you're saying that the results and the clinical effect is, the clinical differentiator of the effect is clinical magnitude is very small. It is only the statistical implications that you're looking at. So I think it's more a game of numbers which has come into play. And what we really need to look at is probably a slightly bigger sample size. We're already teetering at the age of 30. 30 is like, is the minimum that you would go to. Isn't that, Dr. Mathur? Probably, slightly bigger, slightly more rigorous. And then, of course, is the element of the neuroadaptation. We are not really looking at the neuroadaptation component of it, even though, when you're looking at the reading speeds, a part of it is being evaluated, but that is, a different arc. So, yes, I think one part of it, the truth is that, blending is here to stay, mix and match is here to stay. And I think clinically, I'll agree with Dr. Mathur's approach that, if the patient is happy, you go in with the next one. If the patient is not happy, then you try a different approach. So we at least, clinically, we don't want to fix something which is not broken as yet. And so far as the article itself is concerned, probably, we need to look at a bigger sample size, because it's just teetering at that age of significant clinical significance.
Agreed, sir. Yeah.
Agreed. So with that, we come to the end of this journal club. I thank all the presenters and the mentors for their very, the excellent presentations. And I also thank our panelists for the very relevant points that they made. I think both these articles were very innovative, and, they've given us a new perspective and given us ample food for thoughts, and also something that we can actually apply to our clinical practice. So thank
Ma'am,
you
could
all.
I take this opportunity for one announcement? Ma'am, I thank the ARC, the AIOS for giving us this opportunity. And ma'am, we're actually coming back with our research methodology workshops after almost, 1 decade. Dr. Nayak and like Dr. Nayak, me, and we had a team. We were doing it something like 15 years ago. So all those who would like to join us as faculty, we will be reaching out to you. So I request you to please join us as faculty. And I think, with your permission, ma'am, if I could extend this invitation.
Okay. Thank you. So
Thank you,
once
ma'am.
again, thank you all. Thank you so much for your
Thank you.
presence here this evening. And
Thank you, ma'am.
for the PGs who have logged in. So just to re-emphasize, we have this ARC teaching program every Thursday. So next Thursday, again, do remember to log in at 8 o'clock, and there'll be something very useful for you all. So
Thank
with
you.
that,
Thank
a very good night.
Thank you. Thank you so
Thank
much.
you.
Thank you.
Thank you
Thank you,
again.
sir. Thank you, ma'am.